just to get some more general things about your work, what is your laboratory called and what does it do?
Well, my laboratory is actually called the Stem Cell Sciences Laboratory, which is reasonably predictable, I suppose. We actually inhabit the very room in which penicillin was first developed as the very first antibiotic. So we actually have a claim to fame, but not because of our own work, it's because of somebody else's. But it's wonderful to work in a laboratory which has that kind of level of history associated with it. And in some ways, there's some continuity there between antibiotics and stem cell biology, because it's largely because of the use of antibiotics that people are living to such old age. Without antibiotics, people were dying in their 40s, early 50s, but now, of course, we live to our 80s and 90s, sometimes up to 100. And it's because of that that we're seeing these degenerative diseases and the need for regenerative medicine. So there is at least some continuity there in the themes that have been studied in the room which my laboratory inhabits. And so we're really working on regenerative medicine, but also the immunological aspects of regenerative medicine, trying to get over some of the barriers to regenerative medicine that immunology actually poses.
What are the immunological barriers to regenerative medicine and how might they be overcome?
Well, it's quite an important area at the current time, because immunology is seen to be one of the greatest barriers to actually bringing this vision of regenerative medicine into the clinic. We can, in fact, produce these iPS cells, induced pluripotent stem cells, in an autologous fashion, so we derive them from the patient themselves. But that is a very time-consuming and also potentially economically unviable way of treating large numbers of people. So the best way forward would probably be to produce a bank of these induced pluripotent stem cells, which can then be used to try and treat patients, which can be matched as best as possible with them and their needs. The trouble with that is that these cells will then be what we call allogeneic to the recipient, so they will be genetically dissimilar. And so they will be rejected in much the same way as an organ would be rejected in transplantation. And so we have to try and overcome some way, or find some way of stopping that rejection from happening. Otherwise, we've effectively achieved nothing by transplanting them with these new cell types. And so my lab has been working on protocols for the induction of what we call immunological tolerance, which would stop the immune system recognizing those tissues as though they were foreign, which is a little bit easier said than done, to be honest, but we are working on various approaches to trying to induce this immunological tolerance.